Hello, and welcome to the Clinical Care Options Podcast. I'm your host, Sarah Anderson. In episode 3 of this 3-episode series, we hear from Dr. Kris Kowdley from Washington State University and the Liver Institute Northwest in Seattle regarding 3 key PBC studies presented at AASLD 2023. The studies he discusses include an evaluation of real-world outcomes in patients treated with an FXR agonist as second-line therapy, lessons learned from PBC outcomes trials, and a late-breaking study of PBC treatment using an FXR agonist plus a fibrate. To follow along with the accompanying commentary, please visit the link in the show notes for this episode. Now, let's get started and hear Dr. Kowdley discuss key studies on PBC from AASLD 2023.
I'm going to be reviewing 3 abstracts that were presented as posters at the recent AASLD meeting in Boston. And the first examines clinical trial and real-world outcomes in patients with primary biliary cholangitis who were treated with obeticholic acid per the current U.S. label. So in way of introduction, obeticholic acid received accelerated approval from the U.S. FDA as a second-line treatment for PBC in patients who have an inadequate response to or intolerance of ursodeoxycholic acid. And after obeticholic acid was approved by the FDA, it was recognized that there were some patients who had decompensation of their liver disease or possibly worsening liver disease that resulted in negative outcomes in patients who were treated with obeticholic acid. So as a result of this experience, U.S. prescribing information was updated in May of 2022 to limit the use of obeticholic acid in patients with PBC who had decompensated cirrhosis, a prior decompensation event, or had cirrhosis that was compensated but had evidence of portal hypertension that was clinically significant. Examples would be presence of esophageal varices, or thrombocytopenia in the setting of splenomegaly. So the purpose of this abstract, which was presented as a poster, was to examine the time to study outcomes for patients who were eligible for treatment with OCA or the current label in a fully real-world study called the HERO study, and to examine how patients did in the phase 3b/4 COBALT outcomes trial that also included an external comparator arm. So the endpoints for the study were the composite endpoints for both studies that included all-cause death, liver transplant, or hospitalization for liver decompensation, such as variceal bleeding, uncontrolled ascites, or hepatic encephalopathy. The COBALT trial also included patients who had MELD scores of greater than 15. In the HERO study, which is the real-world database, we don't have these data, so we cannot assess MELD score. So the populations that were studied here were the HEROes patients who came from a U.S. Komodo healthcare map claims database. Tokenization methodology was used to match patient records across health plans without sharing PHI. Standardized morbidity ratio weighting was used to ensure the cohorts had comparable characteristics. And for comparison with the COBALT analysis using USPI or US package insert, the composite endpoint was analyzed in a subgroup of patients with evidence of portal hypertension. We also had patients who met COBALT trial eligibility during the recruitment period who were identified from this Komodo database. Statistical analysis that we performed included Kaplan-Meier analysis looking at time to event, and patients were censored at study discontinuation, database disenrollment, or loss to follow-up. Cox regression analysis was used to estimate hazard ratios and 95% confidence intervals. So when you look at the baseline characteristics in HEROes, patients who were treated with OCA versus non-treated with OCA were similar. But patients treated with OCA were significantly less likely to experience a composite event with a hazard ratio of 0.41, meaning that the risk reduction was almost 60%. In COBALT, looking at the external controls, after similar weighting was done, baseline characteristics were also balanced between the external cohort and the randomized control arm, patients treated with obeticholic acid were significantly less likely, again, to experience a composite event compared to those who were not treated. And here the hazard ratio was 0.36. So the reduction in the hazard of the composite endpoint in USPI patients treated with OCA in the COBALT external analysis was also consistent with that observed in the real-world HERO study. So what does this study actually mean? What this study shows us is that when we look at the HERO's real-world data and the COBALT external control, it demonstrates that obeticholic acid did improve event-free survival in patients who were treated according to the updated, more recent labels. Real-world studies, therefore, are shown to be useful when functional unblinding, and I'll talk about this in the second abstract I'm going to describe, compromises randomization and commercially available therapies may lead to treatment crossover. So in summary, what we've learned is that if you identify patients who should be treated according to the current label, we see that patients appear to benefit from treatment with second-line therapy with obeticholic acid, if used appropriately, and both in a pure historical control database and in a matched external control database from the COBALT study, the risk reduction of a composite event, meaning a risk of a clinically significant adverse liver event, was significantly reduced, in one case by about 60%, in another case by about 64%. So this information should be helpful to the audience as a way of trying to obtain information about the possible benefits using external or real-world controls when a confirmatory trial, that is a randomized placebo-controlled trial, is not feasible or may not be done. So we'll now go to the next one. And the next abstract here is somewhat complex topic, but clinically extremely relevant. So obeticholic acid was approved in 2016 based on a surrogate endpoint of alkaline phosphatase improvement to less than 1.67 times upper limit of normal total bilirubin level with at least a 15% reduction. And this was based on population data showing that reduction in alkaline phosphatase conferred improved long-term clinical outcomes. Based on this, obeticholic acid received conditional approval with the expectation of conducting a confirmatory trial that actually showed improved clinical outcomes with treatment. And that was the purpose of the COBALT trial. And the COBALT trial started enrolling patients before FDA approval for obeticholic acid, but continued to enroll patients after FDA approval for obeticholic acid in the US. We've talked about obeticholic acid already as second-line treatment. And the purpose of this abstract, which is titled The Challenge of Confirmatory Trials in Rare Diseases, Lessons Learned from the COBALT Trial in PBC, really emphasizes the challenges of trying to recruit and complete a clinical trial that is placebo-controlled with potentially a sicker population of patients being enrolled and potentially randomized to placebo when the active drug is commercially available and patients can seek from their own doctors to get their blood test monitored and may choose to drop out of the study. This is in some ways called functional unblinding and really speaks to the challenges of continuing recruitment when a drug is already available in a placebo-controlled trial. And that's in fact what happened to the COBALT trial. COBALT trial was stopped because of futility in that not enough patients were enrolled to achieve clinical outcomes. So the purpose of this study was to examine what could be the factors that led to the study failing to meet its goals, and could it possibly be related to the so-called functional unblinding and the possibility that patients may have left the study voluntarily disproportionately in the placebo group. We see there were no treatment differences between obeticholic acid and placebo because not enough events were reached. In both groups, there was a reduction in alkaline phosphatase over time. And what we did learn was there was evidence of informative discontinuation and treatment crossover to commercial obeticholic acid in the placebo group. So if you look at the mean alkaline phosphatase levels in the placebo-treated patients who discontinued study medication, they were greater among patients who remained on the study for more than 6 weeks, and they remained on study medication for 4 of the 6 periods. That suggests functional unblinding. And what does that mean? If you look at mean alkaline phosphatase reducing in both treatment groups, but the magnitude of the decrease in the placebo group was much greater than in the obeticholic acid group. So what that tells us is that if you look at the likelihood of initiation of commercial treatment with available obeticholic acid, you can see that in the obeticholic acid group, the alkaline phosphatase levels reduced, but they reduced to a greater degree in patients who were on placebo, showing that they were switched over after leaving the study. So a complicated concept, but essentially what we've learned from this long-term outcome study is that different trends in the levels of alkaline phosphatase between 2 treatment arms led to functional unblinding and treatment crossover in the placebo group that compromised the assessment of the study objective and biased the results. And what this really is a lesson is that using a surrogate endpoint to approve a medication followed by a confirmatory trial when the medication is in fact already available to patients, and there are no ways that we can guarantee the patients could not unblind themselves. They could go to their local doctor, get their alkaline phosphatase checked, or based on symptoms, choose to leave the study and then request open label treatment. This poses a significant challenge in terms of a placebo-controlled trial and really speaks to the need, particularly in a rare disease, for utilizing other types of data such as real-world controls, real-world evidence, external controls to try and achieve the answer that we are trying to understand, which is, does the treatment improve long-term outcomes? So I mentioned, we talked about obeticholic acid as second-line treatment. It's the only approved second-line treatment in the US after ursodeoxycholic acid. Over the past few years, we have seen the adoption of multiple combination therapies. Bezafibrate is a fibrate, a pan-PPAR agonist that has been used to treat PBC in Japan for many years and in Europe for many years. And bezafibrate has been shown to significantly improve alkaline phosphatase levels, and in Japan, based on population-based data, has been shown to actually lead to similar reductions in liver-related adverse outcomes as what we were examining with obeticholic acid in real-world cohorts. There is now an increasing momentum to achieve greater levels of alkaline phosphatase improvement in patients with PBC. And in fact, there are recent data from the global PBC study group showing that patients that have alkaline phosphatase levels that are any level of elevation above upper limit of normal are still at increased risk of adverse liver outcomes, not just 1.67 or twice the upper limit of normal. So this has led to enthusiasm about adding combination therapies. So utilizing both a fibrate as well as obeticholic acid in addition to baseline urso therapy. So the purpose of this study, which was combined effect of obeticholic acid and bezafibrate in patients with PBC with an inadequate response or intolerance of ursodeoxycholic acid, was to present the results from 2 phase 2 trials. So patients who were included were those who had an alk phos greater than 1.5 times upper limit of normal. In one study, patients were randomized 1:1:1:1 to receive once daily bezafibrate, 200 milligrams, immediate release, 400 milligrams, sustained release, obeticholic acid titrated to 10 at week 4 with bezafibrate, immediate release, or obeticholic acid 5 milligrams titrated to 10 milligrams at week 4 with bezafibrate, 400 milligrams, sustained release, all for 12 weeks. In the next study, patients were randomized 1:1:1:1 to receive beza 100 immediate release, beza 400 immediate release, OCA at 5 milligrams with beza at low dose, or OCA at 5 milligrams with beza at high dose. And both of those were immediate release. The main outcome measures were percentage change in normalization of serum biomarkers, biochemical remission, defined as alkaline phosphatase, GGT, ALT, and AST, all less than upper limit of normal with a bilirubin less than 0.6, and safety events. Baseline demographics were balanced between the different cohorts. So when we look at the combination therapy effect in terms of biochemical remission at week 12, we're seeing 40% and 44% of patients achieving a biochemical remission. So this is very exciting because these results suggest that short-term administration in this study was generally well tolerated and has a potential to normalize multiple serum biomarkers. Another very attractive aspect of this combination is that obeticholic acid's main liability is dose-related pruritus, and bezafibrate has been shown to improve pruritus. And in fact, low rates of pruritus were observed in the OCA Beza 400 sustained release group, which were substantially lower than in the phase 3 POISE study. So based on this, the authors concluded that further development in a phase 3 trial with a sustained formulation of bezafibrate with low doses of obeticholic acid is indicated. So in summary, we are now seeing that if you look at improvement in alkaline phosphatase, this was greater than 60% reduced in patients who were treated with the optimum dose. Over 90% of patients achieved total bilirubin less than 0.6. And if you look at normalization rates for liver enzymes, that was achieved in almost the vast majority of patients. So this combination now, I think, is generating excitement as potentially a triple combination that might achieve the true goal of normalizing all the liver biochemical tests in patients with PBC.
I'd like to thank Dr. Kowdley for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the commentary for this podcast and the full program on CCO independent conference coverage, updates in primary biliary cholangitis from AASLD 2023, on the Clinical Care Options website, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important liver-related topics. Thank you.